honored that I've been asked to share my knowledge about atopic dermatitis, which is one of the most common walk-in patients in our clinics. And even if they don't report in clinics, I'm sure we all come across such patients literally every day. So I'll be sharing a comprehensive review on advancing pediatric eczema care. So will you please go on the next slide? I'm sure Cheryl has comprehensively talked about eczema, and you must have got a nice overview of it, but just to review it quickly, with the definition of atopic dermatitis, it is basically pruritic eczematous dermatitis, and its symptoms are chronically fluctuating between remissions and relapse, and most individuals have family history of it. Typical cases are having a symmetrical, dry, itchy, and inflamed skin on a certain areas. I will describe the certain areas in a short while. And it affects almost 10 to 20% population, children population. 50 or to 60% resolves itself by puberty. And unfortunately, whoever stays after puberty, they suffer lifelong. So the next slide. So there are different diagnostic criteria of atopic dermatitis. I'm sharing here with a very, very basic diagnostic criteria. One of mainly these three things: the pruritus, typical morphology and distribution, and chronic or chronically relapsing course. These are main three factors that should be present to diagnose a case of atopic dermatitis. And moving on to the next slide, I will share what is the diagnostic criteria of eczematous dermatitis. There may be acute lesions, which are erythematous, the red, scaly, exudative papules, and there may be oozing in it, and there are scales and crusts on it. The acute lesions are typically like this. And when it is a chronic lesion in a child, they are infiltrated erythema and lichenification. I hope you guys are familiar with these terms. Lichenification is basically thickening of the skin, and there is, of course, a lot of prurigo or itching and scales and crusts over the lesions. Typical distribution is they are mostly symmetrical, and predilection sites are basically forehead, periorbital area, around the nose, around the lips, periocular area, and neck and joints, especially the flexor sides, the inside of the elbow, and outside of the knees, and trunk area or forehead, scalp. They're all involved in a symmetrical manner. There is age-related characteristics, like in infantile phase of childhood or adolescence, adult phase, the distribution changes with time. In infantile phase, typically you see it on the scalp, on the face, and on the trunk around the neck. And in childhood, as the child starts crawling, it goes to different areas like flexures of the arms, neck, and trunk as well. In adolescence case, mostly upper body is involved, scalp is involved. And the course is, of course, I have said again and again that it is a chronic relapsing course. If it is more than 2 months in a child, it is called a chronic, in infant, it is called a chronic case. If it is more than 6 months in the childhood and in adolescence case, it is again a chronic case. Definitive diagnosis of atopic dermatitis requires the presence of all three features without any consideration of severity. Moving on to the differential diagnosis, it can be confused with many other skin conditions, as is most, misdiagnosed case in our practice. So it could be a contact dermatitis, it could be a seborrheic dermatitis. It can look like this, and it can be ichthyosis. It is very, very common differential diagnosis of atopic dermatitis. In ichthyosis, the flexures are spared. In atopic dermatitis, typical case, you watch for the flexures. In atopic dermatitis, they are lichenified, thickened flexures, but in ichthyosis, which is a genetic disease, the flexures are spared. So one has to look very carefully to differentiate between the two. In psoriasis can look very similar to atopic dermatitis. Again, the features are very, very distinct, but they can be very confusing. In psoriasis, the base is very erythematous, and the silvery scale is typical hallmark of psoriasis. While in ichthyosis, the silvery scale is not a mandatory thing. The oozing or the exudate is quite common in atopic dermatitis, but not in psoriasis. Especially you have to look for scalp because the features are very, very similar. Then there is a xerotic eczema that is basically, in simple terms, it's basically the dryness of the skin. So it is, it can be, again, very, very confusing at times, but you have to look for three main features: pruritus and the long course and typical morphology. Moving on to assessment of severity. Assessment is really important because it defines the course of treatment and impact of life. Mild cases in which very mild few lesions are present, quality of life is not disturbed, not that much disturbed, but these are like mild features. In moderate case, eruptions with severe inflammation in less than 10% of the body surface area. When it comes to severe cases, it is more than 10 to 30% of body area, and in most severe cases, it is more than 30% body area. And this severity usually defines the impact of on life and our treatment options. So to diagnose a case of atopic dermatitis and severity, we have certain tests which are very conclusive for the exact diagnosis. So the useful biomarkers, please, next slide. These are serum IgE levels. This is a very basic test which defines more than 500 international units of IgE levels on a test, helps us to make a definite diagnosis. And it describes disease progression as well. Then there is specific IgE levels, which is more advanced than serum IgE levels, and it detects the basic allergens which may be involved and responsible for sensitization of the skin. Then there is peripheral eosinophil count. I'm sure you have read about etiology of the such diseases. Then the eosinophil counts raise in such cases. There is hypersensitivity reaction going on in the body, and the eosinophil counts raise. Then a more specific test is serum LDH level, which is lactic dehydrogenase levels. These are more specific, more specialized test for atopic dermatitis. Then there's serum TARC levels, which is thymus and activation regulation chemokine. It reflects disease progression more than serum IgE levels. LDH and eosinophils count as well. Then again, a very, very specialized test is squamous cell carcinoma antigen levels. It sharply reflects the disease progression. These are very advanced levels, advanced test for the exact diagnosis and disease progression. So next slide. So the most important thing in eczema is early detection and intervention, because in my practice I tell my patients that if you maintain a lifestyle, you can save a lot of bucks, because otherwise patient will just keep on coming back to your clinic because the disease is chronic, it is always relapsing, and remissions are they're just going to and fro. So to save those money and time of the patient, and of course the mental toll of the parents and the child himself. To save that, we have to detect the disease earlier on and start or maintaining the lifestyle as soon as possible. And the proactive management improves symptoms and quality of life markedly. So the basic thing, next slide. So the basic thing is individual care, because we have to look multiple sides of the patients, the economics, the lifestyle, the family support system, because we have to, we have to maintain a skin barrier. And for that, especially in a child, we need a constant care, maybe like 10 times a day. So for that to happen, you have to, maintain a very consistent routine. And for that, individualized treatment options or treatment style is very important. And we have to collaborate decision making between health, with the patient and the family and the healthcare provider. They should work together to, maintain that lifestyle. So I would always emphasize on individual care, individualized or personalized care. The basic treatment, next slide, is a topical moisturizer. First and foremost, and simple routine. You cannot complain of budgets, or you cannot complain of accessibility. A simple moisturizer. Typical moisturizers that we can use is Vaseline, white petrolatum, or even the simple even that oils are very important, or they can be commonly used, like coconut oil is a very good topical moisturizer, and it has been proven that it works wonderful in atopic dermatitis. The use of moisturizer product improve moisture content in the stratum corneum, which is decreased due to atopic dermatitis, again because due to dryness and due to loss of moisture, the skin barrier is disturbed. So topical moisturizer gives a nice shield around the body, so the invasiveness of the allergens that may aggravate the disease is ceased. So the nice moisturizer will protect the body very nicely. And these are like basically water-loving ointments with moisture-retaining property, and water-absorbing ointment, including heparin-containing and urea-containing products. They're very helpful. And zinc oxide and white petrolatum, as I have said already, are more effective when applied twice a day and immediately after bathing. After bathing, the body is moisturized, it is dampened. When any product, urea containing or petrolatum, is applied on the body, it absorbs very nicely, and the skin is ready to take that moisture into it, and it is very helpful. In books, it is said that twice a day or thrice a day, but in our clinical practice, I literally advise patients or their parents, especially because patient is usually very small baby. So I advise them to literally apply these moisturizers every 3 hours, because changing diapers, our clothes are, since it's winters, the clothes are very abrasive at times. So the skin barrier should be maintained, and maybe the topical moisturizer may be applied multiple times a day. Then bathing, showering, and washing. These are, simple techniques or simple things that we do every day, but doing it in a right way is very, very important in atopic dermatitis, because, these days, since it's winter has begun in Pakistan, so bathing is really, sometimes it can make or break the case. We love to take shower in like the hot shower, but very hot showers, like more than 42 degrees, that can induce itching, so it can make your child more uncomfortable. And then the long showers, we love to take long showers, so of course it's very soothing as well, but long showers, high temperatures, that can break the barrier system of the skin. So then we love to sometimes use that loofah for for rubbing the body so that all the milk gel will go out, but it is sometimes a very abrasive for the skin, especially for your child. So that is important to take a very mild bathing in a very nice temperature, less than 42 or maybe like 36 degrees temperature, and which is which makes your skin barrier intact, and small brief showers with mildly irritant and unperfumed, unscented soaps or body washes. Very mild should be used so that the skin barrier is intact, and uh, the bathing and showering and washing procedure does not add to the disease. So, and then after taking all these measures like topical moisturizer and bathing, search for exacerbating factors. These can be exogenous factors and endogenous factors, which can, despite all the care, can aggravate the disease. The exogenous factors may be, again, the soaps. We love to get intimidated by TV commercials and use those fancy soaps, which are when a savior will come and kill all the bacteria, but that can be irritant, or allergic reaction can be produced by those soaps. So we should avoid that. And then the endogenous factors, there could be underlying skin conditions that can be detected on tests that I have mentioned earlier. The use of sprays and use of perfumed items can cause, can increase the disease. So these should be searched very meticulously and shall be excluded from the life, because that can add to, the agony of the patient. So moving on to the next slide, the medical treatment after lifestyle is mainstay is topical steroids. And in my practice, I prefer that a mild steroid shall be initiated first, and then moving on to moderate or severe or more potent steroids, because as we all know that steroids are a very bad servants if they're like given on loose. So they should be carefully selected according to patient's site of lesion, according to age, and according to disease severity. So the topical steroids are, however, they are the mainstay of treatment. They're very less expensive. They're easily available, but should be tailored according to patient's need, and very, very carefully selected after maintaining a lifestyle. When there is exacerbation of the lesion, after that, topical steroid can be prescribed. Um, then there is this, not very new, but there's another drug, which is tacrolimus, which is very, very safe drug to use after steroids when patient is in remission and relatively in a safer zone. Then to maintain that, we can prescribe tacrolimus. In children, we prescribe 0.03% of tacrolimus for a certain time and to avoid side effects. Then choosing topical steroids for atopic dermatitis is a very, very huge topic. I would love to talk about it maybe later sometime, but this is another chapter in itself. So proactive therapy is used to maintain remission via application of topical steroids or intermittent topical tacrolimus. So we sandwich these two drugs to avoid side effects and to maintain a great prescription for the patient. And using it like twice a day, twice a week, we use tacrolimus, and on other days, we can use topical steroids, and of course, after maintaining a lifestyle. So This is a proactive therapy. And then there is dry bandages and medicated dressings, including wet wraps. Dry bandages, these are not available in Pakistan, but they can be, improvised. They can be told to patient to, we can makeshift these dry bandages in West or in Europe and in UK. The dry bandages suits and medicated suits are available for children, in which the underlying layer is of a moisturizer, followed by, which is occluded by a dry bandage, so that all night that moisture and drug sometimes can go just directly into the patient and does not get disturbed by dressings or blankets or whatever. So this is a very, very effective treatment, although sometimes very disturbing for the patients, but again, it is very effective. So the occlusion is really important, and it is very effective. I usually tell my patients, especially when the patient is in adolescence phase, or maybe like a toddler, that is quite doable. But in children, sometimes it is not, because it is very disturbing at times, but effective. So coming to oral treatments, we reserve oral treatments for, again, a severe cases. Antihistamines can be given because because for all the pathogenesis and etiology of the disease, it aggravates at night. So sometimes patient is restless all night, and it is of course very disturbing for the patient himself and the family as well. So we have two options in antihistamines: either first generation, which is sometimes sedative, patient can sleep nicely at night, and sometimes when the child is school going, we can prescribe a non-sedative antihistamine. They work wonders. Non-sedatives are relatively newer drugs, and of course, they're more appropriate with lifestyle. Cyclosporins are reserved for adult cases, very effective. And oral corticosteroids, again, a very, very magical drug for the case, but it is also reserved for severe cases, because we can prescribe oral corticosteroids on first visit of the patient as well, and he'll be fine like in 5 days. But since the disease is chronic, it has relapses and remissions, we cannot toll his life by giving oral corticosteroids repeatedly. So personally, I would like to keep this drug for severe cases, and after repeated counseling, after maintaining a nice lifestyle, still if the disease is exacerbated at some point, then oral corticosteroids can be given for a short time and under a strict monitoring and strict supervision. So these are emerging therapies and innovative approaches. Ultraviolet irradiation, when the child is not responding to oral treatment and lifestyle and oral corticosteroids even, then ultraviolet radiation can be given. And it's very effective, safe as well. So the devices are available, and that can be prescribed. Even at-home devices are also available. These are like basically 311 nanometer UVB light is given to the patient, and it is exposed to the patient. Sometimes it is adjuvant therapy with oral corticosteroids as well. So okay, so the new thing is probiotic and prebiotics to modulate the gut microbiome. It is like the thing that is a live microorganism is introduced in the body, which is already present, but sometimes in children it is not. So these are introduced in the body, and that can boost your immunity, and that works very well to treat atopic dermatitis. These are certain foods are also available. Some certain drugs are also available. So they work together to help the patient. Moving on to the next slide, these are diagnoses of infectious diseases, because Atopic dermatitis is a playground for infections. So sometimes bacterial, fungal, and viral infections like bacterial like impetigo, erysipelas, these are common on atopic skin. The viral, especially a very, very emergency condition is eczema herpeticum, which grows on atopic skin. Then that can be life-threatening disease, viral disease. And again, fungus can grow. Candida is common, maybe sometimes secondarily because of the corticosteroids, oral or topical, but when it is present, these should be treated as well, because sometimes the bacterial or viral infections are more dangerous than the topic itself, because the topic will stay for sometimes for life, but these um, infections can be very disturbing for the patients because they can cause a lot of different things like fever and other symptoms as well. And as I've told, viral infections like eczema herpeticum can be life-threatening. So this should be early intervention and early diagnosis of these infections in atopic dermatitis is very important. So the last but not the least is FDA-approved new biologicals. I hope you have heard about biologicals, and these are very, the new drugs and very, very aggressive and very, very, the life-changing kind of drugs. These are expensive, very expensive for Pakistani population, but these are effective. Even this dupilumab, which is interleukin-4 receptor antagonist, is present even in Pakistan. And there are two types of drugs that are available, and these are pre-filled syringes of 300 milligrams for that can be injected at home even 4 weeks apart. It does wonders, but unfortunately, these are only for the a patient who can who can afford it. But with this drug, relapses, the patient goes into remission very, very quickly, and other symptoms like allergic rhinitis or other like topic related the symptoms are very, very nicely resolved. But the main side effect is it is expensive and cannot be prescribed in every patient. So that's it. I hope you guys have had a nice overview about the treatment of the atopic dermatitis, and I hope you guys got some take-home message. But my message would be, take-home message would be that to keep skin barrier intact, the main treatment is to keep, all dermatology is basically to keep skin barrier intact. Whenever the skin barrier is breached, a disease can occur. Basically, it occurs because the skin barrier is breached. But especially in atopic dermatitis, the mainstay of treatment is to resume the skin barrier. And for children, it is very important because unfortunately, they cannot talk much, they cannot express much as adults can. So a very vigorous and very, consistent care is really important. So I hope you understood and have a nice overview of the topic. If you have any question, you're most welcome. And I thank you all, and I'm really grateful talking to you. If you have any questions, please feel free to ask. Thank you so much.
Hi, Dr.
Assalamualaikum, Dr.
Sarah.
Sar.
Welcome, Sam.
I hope you are fine and doing great.
Thank you.
It was our honor to have you with us today. I got a question for you.
Sure.
What are the common misconceptions about the eczema that we should be aware of? And are there any recent advancements or breakthroughs in eczema research or treatment? As like you have discussed earlier about emerging therapies and innovative ideas, are there other methods on which we can rely on?
Okay. Common myth is, again, using these antibacterial soaps, which are fancy TV commercials that show that killing all the bacteria is very good. But the myth is that we need healthy bacteria on the skin, which are important, which are installed nice bacteria that maintains a skin barrier, but we deliberately break that barrier by using these antibacterial soaps and detergents and alcohol swabs and all these things that are very disturbing for the child. So the myth is that killing all the bacteria is good for your skin, but it is not. And the second question was, please again.
Any recent advancements or breakthroughs in eczema research or treatment? Like you have discussed earlier about the emerging therapies and innovative ideas. Are there
So
any
the
other
recent
methods on which we can rely on other than these?
Okay, the recent and the most advanced is, these biologicals. These are recent and very, very advanced, and they work wonders. And but unfortunately, these are not very, very cost effective. But again, whoever can afford it, it's a must try thing. And the other methods on we can rely on is my opinion or my uh, you know 2 cents is to keep a healthy lifestyle for your child and keeping your child very, very well moisturized. This is the only thing that we can rely on. Maybe sometimes corticosteroids won't work, other oral or other advanced medicines, oral or topical, won't work. But if you maintain a lifestyle and keep the skin very moisturized, that is the only thing we can rely on.
Thank you so much, Dr. Sarah. Totally satisfied with the answers.
Thank you so much.
I have a question. Like as you told before about the corticosteroids, so how you counsel
Mhm.
your patients about the use of oral corticosteroids,
Okay, this is very
especially the
important
later
question, basically. And again,
infant.
I've mentioned it earlier that it is a whole topic in itself. Counseling a patient for using corticosteroids, you have to make a written statements, and you have to clearly mention in their language that how long the drug has to be used, what is the time to give the child the medicine, because corticosteroids timing is really important, and for how long it is given and the dose is really important. So you have to invest in time and counsel your patients about it, and make sure that the drug is given in for a certain time, because after that the side effects will kick in, and that can be very debilitating for the patient and for the family as well. So investing in time basically and talking to them in their language is important, and making sure that you have good liaison with the pharmacy as well, so that the patient does not have free access to all the drugs. So if you ask me personally, I have liaison with my pharmacy that the patient cannot get the drug without prescription, without exceeding the time that I prescribed for. So, but unfortunately, in our society, it is sometimes not every time it is possible. So, you have to counsel the patient and tell him repeatedly, and talk to him very thoroughly, very frankly about the drug and the intake and all. So yeah, so time basically. Talk to your patient's attendant.
Thank you so much. We extend our gratitude to Dr. Sara for her incredible presentation, which was truly worthwhile. Once again, we would like to express our thanks to both of our speakers for their valuable contribution to this webinar. Your knowledge and dedication to improving the lives of eczema sufferers are commendable. Thank you so much, Dr. Sara, for joining us.
Thank you.
Thank you so much, everyone.